beautiful Thursday evening, at least in New York City. The weather's very nice. And we have the topic of our webinar this afternoon is quality improvement and implementation science. And we have no other than Adam Thompson, who has been in quality improvement for, oh my gosh, I was still in junior high school when Adam started this. So that's a pretty long time ago. So Adam, thank you for agreeing to do this, and I'm going to turn it right over to you.
Awesome. Thank you so much. It was a wonderful time when you were in junior high school, right? Yes, I really appreciated when the talkies came around and we got to hear what we were looking at. So good afternoon, everyone. Thanks for joining us today. My name is Adam Thompson. I'm really excited to talk about the topic for today's webinar and TA session, which is quality improvement and implementation science. If you are anything like me, lately your world has probably had both of these words coming at you from all kinds of different directions. As a quality improvement practitioner, I kind of started hearing about implementation science a couple of years ago. And as each year has progressed, it's gotten to be louder and louder and louder and has kind of become this concept that sits in our space constantly. And I think that it's really important to understand how these two are similar, but also just as important to understand how these two topics are dissimilar and how they diverge from one another. Having a sort of knowledge and understanding of both will actually make you better quality practitioners, to know when we're on an improvement pathway and when we're on an implementation pathway, and how you use similar tools and methods in each side, but kind of for different purposes. So let me go ahead and bring up our slides. So as I said earlier, our topic is quality improvement and implementation science. By the end of this session, we hope that folks will have a better understanding of quality improvement, and quality assurance, as well as the 6 domains for healthcare quality improvement, where we should be aiming our improvement efforts, and then talking about the research practice gap and how implementation science was designed to kind of fit in that gap. So let's first begin with quality and quality improvement. And I think there's some folks who may not have their line muted. We can kind of hear some wind in the background. So if you're not muted, we invite you to mute your line. So let's start first with quality and quality improvement. So one of the things that I think is important to understand about QI is why we're doing it. I'm a history kind of person. I think knowing why we do something is really important. It got me in trouble as a kid. I'm like the worst with parents. I was like, why? And I have carried that behavior into my adulthood. I want to know why. So when I put these two numbers up, I use these a lot in my lectures. Some of you all may have seen me talk about it before, but if anybody knows what these two numbers represent, feel free to either unmute your line if you want to say it out loud, or you can throw it in the chat room if you know. 44,000 and 98,000. Does that ring a bell to anyone? 44,000 and 98,000. Yeah, Richard put in the chat room, human error, right? So 44 to 98,000 was the number of American lives that were estimated lost to medical error, right? That annually somewhere between 44,000 and 98,000 Americans died in our healthcare systems, not because they were so sick that there was nothing we could do, but because we gave someone medication that they were allergic to. These are the kinds of spaces where we missed a diagnosis because the lab report that told us what to look at wasn't put back in the electronic medical record at the time, where people didn't have the paper chart. There was 1,000 different reasons for this, mostly rooted in communication. This number really kind of sent shockwaves through not only healthcare systems, but I think the United States in general, becoming very aware that we did not have a high quality healthcare system, right? I think it is very hard to say that you are providing high quality care when just under potentially 100,000 people walk in the doors every year and don't make it back out. The other thing that's important to know about these numbers, especially putting an equity lens on this only represents the people who got in the system, right? So there are probably uncounted numbers of people who didn't make it through the door of the healthcare system, who didn't navigate their way in. One of the sort of very tongue-in-cheek ways to say it is, shouldn't we all have an equitable opportunity to be killed by the American healthcare system? So these 44 to 98,000 only represents the lives that made it inside, right? And there are lots of communities, as we know, in our Ryan White program, we serve a lot of these communities who don't perceive healthcare doors to be for them. So these numbers don't even include individuals who didn't make it. At that time, a couple of reports were published to kind of bring greater awareness to this. Right around 2000, just a little bit before, in the winter of 1999, this report was published called To Err is Human. To Err is Human really described this environment. Right at the very first page, they talk about these 44,000 to 98,000 folks, but they also go on to explain what was the problem. Right. And what they saw was that the majority of medical errors that were taking place inside systems were not the result of like bad practitioners. Right. It's not that we had like a healthcare system full of terrible doctors, or we had like these little malevolent nurses running around everywhere trying to kill folks. Like that's not what was going on. Right. What they found actually was that most of the problems were more commonly caused by system problems, faulty processes, right? Conditions and environments that led people to make mistakes or to fail to prevent them, right? So this was not a bad apple problem. We weren't going to be able to go into our healthcare systems and just kind of label people and move them out. That it was really about looking and attending to the systems that were supposed to be supporting healthcare providers and the teams that were caring for patients and the communities that counted on them. Not long after To Err is Human, another report followed that sort of laid out expectations, sort of like a framework for how we could go about transforming our healthcare system. People began using the language transformation to really indicate that what we needed to do with our systems was not just a tiny change, right? To get where we needed to go, we were going to have to really rethink the foundations of how we do things. And really reorganize the entire healthcare system. So in this report, they laid out sort of the 10 rules for redesign. These rules that they laid forth focused on things that were going to help us build this new system that would have an environment that supported providers in decision-making instead of having them have to run around and try to find the information. It was also aimed at a lot of transparency so that people knew what was happening inside healthcare systems, both as the people working within them and people trying to seek care. Another aspect of our change was this sort of, doubling down on evidence-based medicine. I think for those of us who are a little younger and were not around when Dennis was in junior high, it may be hard to know or even remember that, not too far in our distant past, we didn't have like, a database that clinicians went to and looked up journal articles and then went, oh, what do I do in this case? Let me Google and find out. People worked a lot on their medical practice, their opinion, what they'd seen, what they'd known. They would consult with colleagues. People would get the journals and be reading information, but it wasn't where it was today. And so what happened in many ways is our providers were given these fire hoses of information, but what we didn't have were systems in place to help narrow the stream of those fire hoses so that clinicians and healthcare providers could get the information they needed to make the decision instead of having to sift through an ocean of data that may or may not be helpful. Another thing that we recognized was that our American healthcare system was built a lot on adding more, right? Whenever we had a problem, we added more to it, right? Oh, what do we need to do here? Build something new. After years and years and years of adding more and building new, we also landed ourselves in a place where there was a lot of waste in our system. We were doing a lot of things that weren't producing a lot of value. We were paying for a lot of things that weren't producing a lot of value. So a lot of our redesign were around how do we, become hyper-focused on this value, which included things like getting rid of the waste in the system, right? Kind of moving this out. And then another sort of big piece of the redesign here was the movement to team-based care, recognizing that, it was not just enough for healthcare systems to sort of manage the singular disease in front of them, but that patients, clients, family, caregivers, all of the people who use healthcare systems, they were expecting more, right? When we go into a healthcare system as a patient, we want to walk out feeling better. And sometimes feeling better is a pill, and sometimes feeling better is having a compassionate provider who sits and bears witness to your suffering, right? There's not enough people in our healthcare system. And so this team-based care models allowed us to take what are, a lot of very scarce resources and begin thinking about how do we use those resources more efficiently, right? How do we create a team of individuals that include social workers, pharmacists, as well as our traditional clinician members? That also included folks like community health workers, peer navigators, right? Folks whose role it was to help build trust, to help navigate people through systems. All of these redesign rules helped us guide sort of what our quality improvement efforts were going to look like. As I mentioned a little earlier, folks use this word transformation, right? Transformation was our goal. We wanted to redesign, and practice transformation was sort of the strategy that a lot of folks utilized in order to kind of address what these changes needed to be. So practice transformation is sort of referred to as a process of change in an organization, but really it's about reorganizing the delivery of care to advance quality improvement, to advance patient-centered care, and to advance the characteristics of high-performing primary care. It's not like we didn't know what to do, right? What we needed to do was take the things we knew worked, and we needed to make those things working in our environments, right? People know how to follow up on referrals. People know how to follow up on a new diagnosis. What we didn't have were systems in place that supported a lot of that follow-up and referral. We know that individuals, right, have certain behaviors that lead to risk down the road. When we know an individual is pre-diabetic, having the awareness and that information that that individual is in a pre-diabetic stage, it allows us to provide interventions that keep them from developing diabetes, right? Our older healthcare system was a reactive system. You had to get diabetes, and then we would come in and help. Practice transformation was aimed at really helping us move away from reactive systems to proactive and predictive systems. That we can do what Amazon and every other giant company in this country does to predict and know the product you want to buy before you even know to buy it. We have that kind of big data in healthcare. What we weren't doing was using our big data in healthcare to proactively and predict things that were going to be needed by patients and clients, right? And practice transformation was a lot about that. Quality, right? A word that we use a lot here at the Center for Quality Improvement and Innovation is defined as the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge, okay? Quality is defined, this is our very Institute of Medicine, now the National Academy of Medicine. This is the very wonky definition. I would encourage folks, if you want to know what quality means, go ask the people in your community, right? What does quality mean to you? They will likely not say the degree to which healthcare services for themselves increase their likelihood desired of results. What they're going to say is quality healthcare, is on time, right? It makes me feel better. Quality healthcare is responsive to my needs. Quality healthcare is a provider who's culturally competent, who possesses skills and cultural humility, who can have conversations with diverse communities of people, right? That, to me, defines quality. When you look at it from a system perspective, right, quality is a really critical piece of practice transformation, which is why our patient-centered medical home initiative, if folks are familiar with that, a couple of years ago, was a really big thing. A core feature of patient-centered medical homes was the development of quality management infrastructure. But quality has sort of different dimensions to it, right? One dimension that folks are probably most familiar with is quality assurance, right? Quality assurance, while in the quality family, is distinct and different from quality improvement. Quality assurance measures our compliance against standards, right? So if we say we're supposed to do this thing, did we do this thing? Quality assurance is generally a question that is answered by a yes/no response or a checkbox, right? So for example, if we expect that all patients are supposed to see one medical visit in each measurement year, if I ask the question, did all patients receive at least one medical visit in each measurement year? The answer is yes or no, right? That's a quality assurance question. Another example would be the expectation that all of our clients or patients have an annual viral load monitoring, right? So we would ask the question, did all patients receive at least one viral load monitoring test in the measurement year? We can answer that again by saying yes or no. Quality assurance is often what you sort of do when you're looking to see, am I meeting my grant goals and objectives, right? That's a very quality assurance activity to engage in. Quality improvement, on the other hand, is referring to the frameworks that we use to systematically improve care, right? So let's say through our quality assurance question, did all patients receive at least one medical visit? We get the answer no, and we want to do something about that. Then we move out of quality assurance and we move into quality improvement, right? And we begin adopting the frameworks and the methods that are going to help us better understand what's happening in front of us. What does our current process look like, so that we can systematically improve that process, right? By either standardizing a process, right? Or structuring something so that we can reduce the variation, right? If all the staff are doing different things, it's really hard to have a reliable process. So we may want to bring that a little closer. The whole point of quality improvement, right, is that we improve those outcomes so that we can move from our quality assurance question of no to be able to answer that question with yes, everyone got this. But quality assurance or QA won't get you there, right? Quality improvement or QI is the framework that we use to respond to sort of a negative result potentially in a quality assurance question. Quality improvement makes a difference, right, by looking at not just sort of the technical aspects of care, right, things related to safety and effectiveness of a process, but also the experience of care. The way quality improvement goes about doing this is by deeply, deeply understanding the context of the healthcare environment, right? We lean on individuals who work in healthcare, who receive healthcare, to help frame out the understanding of that context. We also, in quality improvement, apply a systematic approach, right? In just a second, we'll talk about how critical it is to have that systematic way that you're doing your work. And this is done by designing, testing, and implementing changes using real-time measurement for improvement. So that as I'm changing something, I'm looking to see and measuring, does it work, before I go and adopt, right, a whole new practice that at the end of the day may or may not work once we adopt it widely. Some principles of quality improvement that I think are important to keep in mind. First and foremost, around the primary intent. The primary intent of quality improvement is to bring about measurable improvement to a specific aspect of healthcare delivery, right? So when thinking about QI and what you're doing in a QI space, it's going to be about improving something, right? Taking an already existing process likely and thinking about how do we make this better. Quality improvement also employs an iterative process of testing change ideas. So quality improvement is rarely about grabbing this one thing and doing it right then and there and making everybody do it the same way, right? What we do is we test and see, does this work? We make changes, we adapt, right? And we retest to make sure that before we have any kind of widespread adoption of a new practice, that it's been refined, right? To be addressed by the context of the environment we're trying to apply it in. Another principle of quality improvement, and I think this is so very important to understand, is that there is a consistent use of an agreed upon methodology. Now, what's cool to know about this? It does not matter what methodology you choose, right? If you want to use, Lean or a Six Sigma framework, you go do that. But if you want to use the model for improvement, you go do that. It does not matter. You are not doing like super better quality if you pick one method over the other. But what is important is that you don't mix them, right? If you are on a lean pathway, you need to stay on that lean pathway. If you are using the model for improvement, you need to stay on that model for improvement pathway. Quality asks you to develop and use a methodology, and you just got to stick with the same one, okay? So you don't need to kind of go out and try to, turbocharge something. All the methodologies work. The key thing is that you have one and that you use the same one. Quality improvement is also about ensuring the empowerment of frontline staff and service users, right? The people closest to the process being implemented are often the ones who know the most about it, right? Those folks are the people who walk through the process users, thinking about clients, patient, family, caregivers, the people that support us, and frontline staff who are often the people implementing a lot of these processes. Process owners, the people who are accountable for the process, sometimes sit very far away from it being done. So if you're sitting in a C-suite, right, CEO, CFO, CIO, and you're trying to improve the quality of care, it's likely you're going to have gaps and you're not going to be very effective if you don't have the folks that are literally sitting at the front gates of your organization. They are going to have often the best perspective on what's going on. Quality improvement also uses data to drive improvement, right? We don't just move on hunches. We don't sit around and think it's a good idea. We find ways to measure and understand that, yes, this is working. And then the last piece of QI, the last principle that's really critical, is that once we know something works and we've learned and we've tested and adapted it into our environment, that we then take that idea and we scale it up, scale it out, right? And help other people adapt and understand. Quality improvement is as much a responsibility to improve our environments as it is to share with others the improvements that we've been able to make in our environment so that everyone can benefit from the knowledge that's been gained through the QI process. When people sit down for quality improvement projects, one of the things that's really challenging is to try to decide what to do. You know, what do we want to improve? We spend a lot of time developing aim statements, problem statements, all these different tools and ways that we go about defining what we're trying to do. Whenever I'm sitting down with a QI project and I'm trying to lay out my aim and better understand, the first question of the model for improvement, what are we trying to accomplish? I go to the STEEP principles. These, again, come out of our Institute of Medicine, right? And what we've got here are 6 places that folks can look to think about where they might aim their improvement. First, safety, right? Is what we're doing safe? We can always improve the safety of care. Second, are we trying to make the care that we offer more timely, right? Is it that we've got a great service and nobody can access it when they need it, that you're 6 months out from that psych appointment, right? If you're 6 months out on the psych appointment, it's not going to work, right? So if you need to aim your improvement efforts at improving timeliness, that's another place to look. We could also be looking at effectiveness or things like efficiency, right? We may have a great process that's not yielding the results we want. So how do we look back at that and say, how do we make this more effective? Or maybe we've got staff who are like, I love doing this, but it's taken me all day. Is there a way that we could do this that wouldn't take as much time on our staffing level by making something more efficient? There's also in our STEEP principles, equity. And I've got to be, real honest. I've been working in quality improvement, as Dennis said, right, since he was in junior high, or 2005. And one of the STEEP principles that I have only, I think, recently been seeing a lot of the teams that I work with aiming improvements around is equity, right? And really assuring that the processes that we're creating, these reliable, high quality systems, are reliable and high quality for everyone. Earlier, I mentioned talking about the 44,000 and 98,000 and was, kind of leading folks to recognize that there are people who, as a result of systemic discrimination, racism, homophobia, transphobia, you name it, like any reason that we stigmatize other and keep people out of the safety and security of society, that is uniquely and keenly felt inside of our health systems, right? I just came back from running a training around LGBTQ plus youth clinics. And, one of the things we talked a lot about in the training was people who say in health systems, well, we just don't have patients like that, right? That's just not part of our community. I can tell you, I grew up in probably one of the most rural conservative places in America, little town in West Virginia, and I was surrounded by gay people and drag queens. So if you are saying these folks don't live in your community, I think there are people who walk in communities that have been systematically excluded from healthcare who have a different narrative about whether or not, those people live in your community. Our communities are more diverse than we think or recognize. And so one of the things that we can look at constantly is how can we aim our quality improvement efforts at equity, right? And really make sure that if we're putting all of these resources into improvement, that those resources are being dedicated to the communities and the populations that have been historically excluded from the kinds of outcomes that our systems are seeking to improve upon. There's also the last domain here around patient-centeredness, right? How do we redesign a process to make it more acceptable, right, to patients, family, and caregivers to be more aligned with their values and preferences? So before moving on, I just also want to sort of touch on quality improvement and equity a little bit more. This is actually from a journal article that was published not maybe 2 years ago by one of our colleagues here in the Ryan White community, Lisa Hirschhorn, who some of you may be familiar with. who does a lot of work in the implementation science space and improvement space both. And they wrote an article about QI and equity. And I really thought they had a really great and simple way to look at this, which is that when you are improving, you are affecting equity, whether you like it or not, right? Any improvement project is going to have an impact. What you don't know is what will the impact be, right? You could have an improvement project that improves for all, but it maintains an equity gap, right? So like everybody kind of got better, but the folks who were behind stayed at the same amount of behind, right? And so they would call that equality and improvement. Everybody got improvement, but you kept a gap in that place. You could also improve something that actually increases the gap. I have seen this occur, right? Where folks were not thinking about certain communities that are walking in their clinics and organizations. And so they designed a process that worked really well for one group of folks, but then the people who were not already feeling supported felt even less supported. And so you could actually increase the gap, right? Another way to think about this too for your improvement is we could actually use quality improvement to decrease the gap, right? To aim our improvement efforts by looking at disparity data, by looking in and seeing, okay, our viral load suppression rate, but what does this look like if we segment these data by gender? What does this look like if we segment these data by race? What does this look like if we look at it from a zip code perspective? You know, two of the strongest indicators in the social risk space are income and education, right? So if we want to sort of understand, is our improvement contributing to equity? The way that you know this is through measurement, which is why we talk about the critical importance of data in quality improvement. You have to be collecting these data to know whether or not your QI efforts are creating a quality and improvement, decreasing the gap, or widening the gap. So after listening to all that, little audience interaction here. What do folks think? Feel free to use this to put it in the chat room. Is improvement a practice or is it a science? Is it the quality improvement science or quality improvement practice? Or I see we've got some rule breakers here going for both. I love a rule breaker. Both. Can it be both? We got questionable rule breaker. I like that. You went to Catholic school, I can tell. Both practice. Some practice. Has to be both. Practice and science with 3 exclamation points, not 1, not 2, but 3 exclamation points. PCN wouldn't be ABN. Oh, if it wasn't improved with practice. I love that. So here's what I'll say about this. I actually fall so much in the middle of this that I actually agree with folks. I think it's kind of a both. And the reason I think it's both is that the methodology part, right? By selecting a methodology and walking through our processes, that's a very scientific-y way to do things, right? It's scientific management, right? We actually have a whole wing, right, of disciplines that talk about scientific management and how you apply these principles into environments. But I think it's also a practice, right? Anybody who does QI will, you have seen them, they love their tools, right? Quality people are all about their toolboxes. And that's like a practice to know which tool to pull out when and how to use it, right? I spend a lot of my time process mapping, which I think is more an endeavor of creativity than it is anything else about how do you visually represent a process so that it's communicated in a way that creates a shared mental model for people. But I think if it's too much practice and you don't have any science, you can get lost, right? And so you always want to make sure that we are using the very best science to guide what we're doing, that we're selecting methodologies and approaches that have some rigor behind them, that have some evidence to say, if we do this thing, we will get this improvement. But also recognizing that if we stay so rigidly in these structures that you might lose the thing that makes quality improvement so great, which is that it really is a space and a place where you can use your imagination, right? We need you to think outside the box, right, in this space. So if you get too sciencey, it can sometimes be hard to step outside, right, and kind of put the mind in that place where there isn't as much structure. All right, so now that we've talked about QI, right, and we understand that QI is the framework that we use to systematically improve care. These frameworks use data and testing and retesting before adopting and spreading, and it's all generally aimed at improvement. taking what we have and making it better. So let's talk a little bit about implementation science. So one of the things that I really love about healthcare is that it is hard to say this is the one way you do things, right? Because we have this context around what we're doing. There are these factors that differentiate healthcare from other industries. Factors include things like duplicate processes, right? Often in systems, we look to reduce waste as part of improvement. And yet sometimes we do things twice because that's a purposeful redundancy. It's a patient safety thing to check this thing twice. In healthcare, we also have multiple decision points, right? Where any, one decision pathway could have 7 ways that could go, right? That is not generally what happens in a manufacturing environment. They like it to be step, 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 right? In healthcare, we also have multi-person tasks, which are really hard to depict, right? In traditional quality improvement frames. It's like 5 people are working all at once. How does that show on a process map? We also have things like mandatory documentation and the use of checklists, where you may be doing 7 decisions at a single step. We also have policies and regulations in place that say you can and cannot do something a certain way. So if the most efficient way to do something conflicts with the policy or regulation, oftentimes we're forced to do that thing in an inefficient way because it adheres to the policy or regulation that's laid out in front of us. But probably the greatest contextual factor affecting our healthcare context are patient, family, and caregivers, right? It's the human beings inside the system, the people that we're caring for. So if you think you're going to be able to standardize patients, you're either brand new to healthcare, right? Or like living in a dream world that we need to burst that bubble and get you up out of there, because you can't standardize human beings. One, they resist it on almost every opportunity because it's dehumanizing, right? To try to standardize people. But it also sort of quashes the diversity and beauty of individuals, right? So when we look in the healthcare context, we have to kind of pay attention to all of these things. And when we're thinking about improvement, this is why we end up with all kinds of stakeholders present at the table so that we can make sure we're attending to all these different contextual elements. But inside our healthcare environments, there are things that can be standardized, right? That's what we're trying to do. We've not sort of this standardization, this idea that there are, one best way to do things and that we should find these best ways are rooted deeply sort of in this concept of scientific management, right? I mentioned that word a little bit earlier. Scientific management is a field that really looks at applying scientific principles in order to improve processes. Well, this has a really fascinating history. Again, if you're a history person and you want to take a look at this, this is a great story. Scientific management, some of the early pioneers of this was actually a couple, Lillian and Frank Gilbreth. If you've ever heard of the movie or the book Cheaper by the Dozen, this was actually written by the Gilbreth's children. So this is a movie about these folks. Frank Gilbreth was actually a contractor who specialized in scientific management approaches. And he got his start by actually watching folks who were doing bricklaying. And what he noticed was that people laid bricks differently. Some were able to do it faster than others. Some were able to do it without being fatigued at the end of the day. And other people did it and the walls were stronger, right? And so he was able to sort of observe by watching others the one best way to do things, right? Thankfully, Frank married someone twice as smart as him, named Lillian Gilbreth. She had an undergraduate and a master's degree from the University of California. She was the first woman to ever speak at the University of California commencement. She also had a PhD in psychology from Brown. This is at the turn of the century. So this is a time when not only were there not an enormous number of women sort of at this level of education in general, but definitely not in fields like scientific management. But what's interesting is Lillian Gilbreth brought in this concept of psychology, right? And she started really making sure that we understood that how the worker feels about what they're doing is a really critical thing to think about. So they ended up creating this type of study that they called microemotion study, where basically they filmed individuals doing repetitive tasks in order to identify the one best way to do something, so that they could then take this one best way and then use this generalizable knowledge about the best way to lay bricks or whatever process they were looking at and take that way of doing things into another environment and say, hey, you're laying bricks too? Awesome. Here is the one best way to do this, the evidence-based practice, so to say, on how you should lay bricks, right? And they, in particular, were the first people to use process maps to kind of teach this to other folks. Well, thankfully, the Gilbreths didn't just stay looking at things like bricks. They actually were very interested in applying scientific management principles to healthcare. And the first place that they went and looked were actually surgical procedures. If anyone knows anything about healthcare culture, that's like going at the holy grail of healthcare. Surgeons are like, you know, very dedicated and very passionate, but also very reluctant to have non-surgeons come in and tell them sort of what to do. The Gilbreths, however, went in and observed, and they were studying surgical operations, and they were specifically monitoring the way that physicians sort of moved in the operating room, because they knew that it was exhausting, that these surgeries took hours and hours and hours. And at the time, right, think early 1900s, the longer somebody is sitting open on a surgery table, the more likely it is they were not going to make it off that table alive. So not only was there a concern about fatigue in the surgeons and what mistakes might happen as they're getting tired, it was also unsafe, right, to kind of leave folks kind of open on the table. So the Gilbreths watched and they analyzed every movement that the surgeons did to kind of see how could we improve efficiency. What they ended up coming up with was that if you were to take something like a cart and you were to, I don't know, lay those surgical instruments out in a specific pattern and in a specific way, and you were to then teach maybe a nurse to hand an instrument in a certain way so that the surgeon knew to grab it without necessarily looking, that you could begin increasing this efficiency by having these standardized ways that people moved and the way that tools were handed and handed back to people. What's really cool, right, is that little operating cart, that way we do things, like that's still how we do it today, right? So the Gilbreths' influence in medicine came up with an idea that now 100 years later is still essentially how we work in the operating room. What's interesting to know, however, is that when the Gilbreths took their idea to the medical community, first to the American Hospital Association at their annual meeting in 1914, Frank Gilbreth announced to them, hey, we've got this great idea, but for this to work, you're going to have to submit to two things. First, you're going to have to let us measure the work that you do. And two, that work is going to have to be measured and analyzed by somebody who's not necessarily trained in surgery, but is trained in this scientific management stuff. So if you have ever been a person who is not a licensed healthcare professional and had to walk into a room of licensed healthcare professionals and tell them how to do their job, I think you know how well this went over, right? It was like a lead balloon. They were like, no way, no how, get the hell out of here, right? So then they said, okay, let's take it over to the American Medical Association. So they went up to the AMA and they said, hey, folks, would you all like to adopt this? In 1915, the AMA said, no way, and they rejected them. But what's interesting, 15 years later, right? 15 years later, the American Medical Association came back and said, hey, just kidding, folks. We really love this idea. We think this is fantastic. Everyone should do this. So in 1930, the American Medical Association formally adopted the Gilbreths' operating room procedures. This is an example of what we call the research to practice gap, or the evidence to practice gap, which is a term used to describe the amount of time it generally takes for us as a community to know that something works before that thing is put into practice by being adopted through like a guideline, and then before a percentage of the population experiences the outcome, result, or receives that service. This is a graph from a publication that recently looked at the research practice gap, which for many years had been estimated to be around 17 years. What this article found was that we'd gotten better. Hooray, we were moved from 17 to 15 years. And so what we have is this situation where we have people who know what to do. And we have people in environments who need to know what to do. But those folks are not the same people, and there were not bridges and pathways for those people to talk. And it leads to things like 17 years, right, before we adopt things like telling people not to smoke, right? That's that teal bar right there. 17 years from knowing smoking was harmful to actually telling people you shouldn't be doing this, right? These things can be affected by factors outside of healthcare. Like if you look, that smoking one is the longest. I'm sure that had nothing to do with lobbying, right? So there are things outside of healthcare that can keep us from adopting these practices beyond just habit and non-communication, which is why folks came up with implementation science, right? Implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services. So see, implementation science is in and of itself definitely about improving, right? But it's about taking an evidence-based practice and putting it into routine practice, all right? So when you put implementation science next to improvement, the subtle difference between the two has to do with what they're looking at, right? When you're looking at doing the right things, right? What practice do I need to adopt? That's the orientation of implementation science. It is about implementing evidence-based practices. If you're concerned about doing things rightly, right? I've already been doing something and I want to do it rightly. That's the orientation of quality improvement, right? Making sure that practices are done thoroughly, efficiently, and reliably. All right. Another way to think about this is to kind of look at where we use these two different kinds of knowledge. Quality improvement produces a specific type of knowledge. It's contextual, right? Whenever we implement a QI project inside an environment, it reflects that environment. It is the result of conversations between the stakeholders working in that environment. It is the result of the policies and procedures that govern that environment. It is very difficult to take someone's QI project out of their environment and put it into another person's environment, right? Because it's so contextualized. Implementation science, however, is about kind of looking at that contextual space and saying, okay, here's this practice that someone is engaged in that is producing this result. Let's say we've tested it and studied it in the environment, and we now want to move it out of that context, and we want to adopt this practice in another space. What implementation science looks for is what is the generalizable knowledge out of that contextual environment, the things that we can extract that will work in a range of spaces and places, right? So it's about the pieces, the lessons learned that are not as contextual, that can be adapted external to the environment. But these things move back and forth, right? Like I could also be sitting in an improvement space and want to grab an evidence-based practice and begin implementing it. So I might reach to implementation science and kind of look at those articles and see what is the generalizable knowledge about what I'm trying to do to inform the improvement project that I may be engaged in. The way to think about this too is about where they begin. Whenever I'm coaching a team or I'm trying to make a determination around which pathway do we need to go down, I will always look at where are we starting from. Improvement projects usually begin with a specific problem, right? We have a low viral load suppression rate. We have a high no-show rate, right? That's a problem. And we want to better understand that problem. So we need to investigate it and we need to understand the context of it in order to think about what changes we could make that would yield improvement, right? That's an improvement pathway, starting with a problem. Implementation projects begin with evidence-based practices. So let's say you're looking at all your indicators and you're like, man, we feel good, but we want to adopt a community health worker for African-American women in our community. There are lots of evidence-based community health worker models. I'm not trying to investigate a problem. I've already selected that I want to adopt this practice. So I'm beginning with an evidence-based practice or an evidence-informed intervention, all the different language we use to describe the evidence, but it's an existing practice that we're going to put into our environment. That's going to take more of an implementation pathway, where we're going to think about, what are the tools and resources that we need to make new into our environment in order to adopt this new practice. These two things are not fighting with each other, right? Right now, I will tell you when I sit in implementation and improvement rooms, I hear like improvement people trying to tell you why improvement is better, and I have implementation people trying to tell you why that's better. In reality, I find that I need both of these skills. I need both of these sort of ways of thinking in order to understand how I can best support an environment or a team. So they work, they're synergistic, they work together. And it really does depend on like where you're moving, and your pathways may actually lead to one another. So for example, if you're an agency seeking to investigate a problem for low performance, you're going to take this improvement pathway, right? So if you're saying to yourself, I want to investigate and better understand, I don't know how to solve this problem, then we need to go down an improvement methodology so that we can better understand what exactly is our problem before we start throwing solutions at it. However, an agency seeking to adopt an evidence-based practice, like let's say you just want to say, we want to adopt routine HIV screening, and we're not currently doing it. That's an implementation pathway, right? It's likely there's a toolkit out there. We're going to go grab the tools and resources. We're going to put them into our environment, and we're going to create a process where there was not one, right? That is an implementation pathway. But it's important to recognize that an improvement pathway can lead you to an implementation pathway, right? You can say to yourself, I investigated my problem, improvement, right? I looked at it, I understood it, I did a root cause analysis, I did a driver diagram, all the QI tools and resources that we use to help investigate and define. And then out of it, once I understood my problem, I decided that we need to adopt this evidence-based practice. Then I'm going to take that practice, and now I'm going to put on my implementation hat. And I'm going to need to think about the implementation strategies that I'm going to utilize to bring that practice into my environment. Things like staff training, things like the tools that I need, the new monitoring, are there new policies and procedures, right? All of the things that exist for our current processes that we're going to need to put in place because this is a new practice. So again, they are synergistic. They are not in conflict with one another. If you are beginning with a problem, you probably want to be thinking about an improvement pathway. If you're beginning with an evidence-based practice that you just want to put into your environment, it is likely that you need to think about an implementation pathway. So with that, we will now open it up. If folks have any questions or comments about this, we've got about 7 minutes left. I'm happy to discuss this further with folks, but I find pulling those two things apart can be really helpful to guide teams in, which pathway do I need to go down, while also recognizing that at the end of our improvement pathways, many times we come to implementation pathways. And I got a note in the chat room. We will definitely share these slides with folks after this.
Yes, the slides will be posted on the CQII website.
The other thing I will tell folks too, I'm seeing in the chat room, clearing it up was helpful. At the end of these slides too is a list of references. In those references are some links to some journal articles that are very accessible. They are not like just so scientific that you can't read them. One is about implementation science and one is just about quality improvement. So you can kind of see them together. I see a question in the chat room. So in an implementation pathway, would the evidence-based procedure be the improvement established in the QI cycle? Exactly. That is exactly it, right? Which is why I think you need both of these things, because once we decide through our improvement that, hey, we want to adopt a patient registry for non-suppressed patients, now we got to think about how do we implement that registry, right? So we don't put off our improvement hat. It's not like we're throwing it away and saying we don't look at that anymore, but we definitely need to think about things that are somewhat outside of improvement, right? Which is about what's just good program management and how do we put those things into place? It's going to look a little bit more like implementing a program than implementing improvement. All right. Well, thank you all for joining us today. If folks have any other questions about this, I'm a big nerd, so I could talk about this forever. So if you want to nerd out on implementation science and QI, let me know. I will also tell you all the other CQII coaches are constantly engaged in this conversation. So feel free to bring this up in your own communities, help other people understand the differences, because we are stronger when we can use both of these tools, right? They're going to make your improvement projects better when you can dip into an implementation toolbox to help you implement the great idea you came up with through your improvement process.
And then let me jump in here quickly, Adam. And again, Adam, thank you so much. This was a wonderful webinar, and by the responses that I'm seeing in the chat, it was very well received. Thank you. So please, we have a poll that went up, and please complete the poll. It helps us as we plan and prepare to introduce new webinar series to you guys. So completing this poll is very, very helpful. Let me also take this time to plug our next webinar, which will be September 29th, and it's Engaging Leaders in CQM and QI. And our presenter for that webinar will be Justin Brittanick. Many of us are quite familiar with Justin. He's wonderful. You know, Adam is great. Justin is just as, you know, great as Adam. So
He's greater. You can say it. Justin is greater. I'm cool.
No, I won't say that. So you won't, trust me, it will be a great treat for you. So we're looking forward to, and please, by the way, feel free to spread the word about these webinar series, you know, share it with others who may not be aware of it. We try to have a broad reach, but we know that there are those out there who may not be, you know, who we may not be reaching. So please feel free to promote the series. So thank you.
Real quick, Dennis, there was one
Sure.
other question in the chat room that I want to make sure that we address, because it's a critical question, which is,
absolutely,
other than the CDC, where can we find evidence-based practices and interventions? So here's the thing. HRSA recently published an article on their implementation science framework. I didn't put it in here because it can be a little murkier, and I wanted to keep this like very clear about these two things. But I would highly encourage everyone to go take a look at this article. What they lay out for you are 3 categories of evidence. One called emerging strategies, which are interventions, strategies, and approaches that maybe do not have a randomized control trial behind them, but have real world evidence or some validity to them based on like, this makes sense to do this thing. Next to that, they have evidence-informed interventions and evidence-based interventions. They are different definitions than the CDC's, so they don't necessarily line up. But what this is reflecting is HRSA has its own pathway of interventions and strategies. So for those of you who are familiar with the Special Projects of National Significance, or the 2IS initiative, or, oh gosh, I'm going to run out of all the acronyms, but the Target HIV Center is where you can find a lot of these resources. The other thing that I would look at, anything that has data behind it, that's been published in a journal article, that's going to be an evidence-based practice. So I know a lot of folks don't have the ability to get articles at any time of the day that you want. It's the best thing about going back to school, I found, is I have access to information. But what I do not want folks to do is think there's no option. Google Scholar is good, y'all. Go to Google Scholar. If you want to know what other folks are doing, Google it. Go see what other people are doing. If you have questions about the evidence, and PubMed, there's another great option, right? Someone one time gave me a very rogue link to a Russian website that'll give you everything, but I'm sure it's very unsafe. But there are ways you can go and get these articles. You can also reach out to your AETCs, right? They often have access to a lot of this information. But if you need any support in this, right, reach out to project officers, recipients, people at CQII, IHI, Institute for Healthcare Improvement. There are lots of places. The last place I'll give you too, really quick, because I know we're running out of time, Healthy People. If you go to the Healthy People website, there is an enormous database of evidence-based interventions. It's done by disease category as well as different communities, and you can go in there and begin looking. Every government agency also has their own database. You can go to SAMHSA, and they're going to have substance abuse and mental health services interventions. So a million different places to go. What I don't want you to do is think that you see a good idea and that doesn't count, right? Good ideas can be emerging strategies. And if you see this is working in the other place, you can still apply an implementation framework, because it's going to require the same things, whether there's a randomized control trial pedigree to the intervention or not.
Great, wonderful. Thank you. Thank you again, Adam. And thank you to all of you who joined us and stayed on to the very end. And also an extra thank you for completing the poll. This definitely will help us. So with that said, everyone have a wonderful rest of the Thursday evening, and until next time, take care.